So we're going to get one great person and one great moderator here. So I'm going to allow Michael McGinnis is one of the few folks, for those who know him, who can speak in an eloquent paragraph and synthesize all the muddiness. So no pressure. We're going to hear from, I think, just his thoughts about, because I think we've gotten a lot. I mean, it's been incredible. Our goal today was to understand where we are and understand the landscape. I think we've done a great ability, and we've gotten an amazing number of different perspectives and viewpoints, even on how we think about it. I take issue, and my favorite comment of the day was, I take issue with the issues. Because I think in some sense that sums it up, where you start and your paradigm, and I think we've even had it as you get to the core of it, these are paradigmatic issues. These are not for the faint of heart, and it isn't, and again, and also where you start in our current system leads you down a lot of roads. So being intentional about where we start and what the definition of the problem and what's in scope and what's out of scope. And we heard it in lots of different ways, whether it's what's in health insurance and what's not, what's the role of a provider and not, interdisciplinary teams and not, how does housing fall into it, what's the role of the individual versus the community. And so drawing boundaries and understanding what's in scope and what's out of scope, because we are great at solving the problem list, not just the medical problem list, but the problem put in front of us. So I really appreciate the conversation so far that we've highlighted that. And the only other point I would make, and then I will turn to Michael, is it does feel like there is a very inherent tension around standardization and flexibility. And I would say, at least my observation is, we don't trust the patient at all today. We don't trust them to make good decisions. We don't trust them to know what's wrong with them. We think they're going to game the system. And if you look at where fraud happens in our healthcare system today, it is not the person ordering the durable medical equipment 1 year too early. But it is interesting. You just see examples on the slides of how little trust we have that families and individuals want to do the right thing, and they want to. When we heard it again and again, people using the emergency room, they have no other alternatives. It becomes a very logical place to get their needs met, an inefficient one and probably not the best. But it just seems about having that fundamental conversation about trust between a provider and a patient, but also who do we give trust to in this kind of future-oriented system. And that's not a technical issue, and there's not a data set that's going to tell us that. But I do think that's kind of one of the core elements. I mean, I think you even heard it in Helen's comment about setting measures, at what level we set them, where we stay, but the standardization and flexibility, and then where we grant that trust and who we trust to kind of do the right thing and to get to the right solution.
Well, thank you, Peter, and thanks to each of the speakers today. Really remarkable discussion, and there's no question that the landscape has been well populated with issues to deal with. And the biggest issue with the issues is their number at this point. But in listening, which is a very privileged status for all of us who are listening today, I think we've made progress. And I'll try to go back to the objectives of the meeting that were laid out by the Planning Committee to reflect on that progress. There are 3 objectives that you see in your agenda related to the identification of key characteristics of high-need patient populations, related to the factors most important to determining the match of a model of care in a patient population, and related to the lessons learned from past experience that might be scaled and spread in some fashion. I think on each of those 3 dimensions, there has been some important progress advanced. First, with respect to the key characteristics, we'd have insights that are important related to the need, related to the cost, related to the data involved. On the notion of need, it's very clear that needs vary across the board, and they're not easily identified simply by counting the conditions, but they need to be assessed quite specifically by looking at functions of individuals, and that we need to keep that prominently in mind when we're characterizing need. Similarly, costs vary substantially, not just among individuals or among conditions, but among time periods from year to year. The costs change fairly substantially. On the issue of data, we heard that the data, at least as they currently are aligned, can be deceptive. That whether it's respect to the classification of diseases that we're using, or whether it's respect to the data sources that we're drawing upon, or whether it's with respect to the absence of information on whole important population groups, one of our charges is to be a little more systematic in characterizing the data needed in order to advance progress in this arena. So we have, I think we've developed some clarity in terms of the identification of the issues that need to be addressed. That's been very helpful, at least from my perspective. On the issue of the factors that are most important, again, very illuminating for me. We've discussed and identified factors related to orientation of the activities, related to the perspectives that shape our work, and with respect to the importance of flexibility. On the notion of orientation, it's very clear, and has been said over and over again, that the orientation has to be to the patient, to the person, and their individual goals. And Peter made reference to the fact that a report from the Institute of Medicine recently gave emphasis as one of the vital signs of the nation to care match with patient goals. It's very clear that's where things need to start, not with an orientation to the condition, not with an orientation certainly to the facility or the provider, but to the person that's right in front of us. On the notion of perspective, it's similarly very clear that the perspective needs to be well beyond the medical condition. The perspective has to be focused on the social, the behavioral, the environmental issues involved. It gets back to the challenge that we have with a segmented system that forces itself to be using lenses that are far too narrow in scope and in direction. So our perspective has to be looking at the entire range of issues that are confronting an individual patient. On the notion of flexibility, that was another factor that was importantly identified in determining the match between the model of care and patient population. That is flexibility not just to accommodate variation among individuals who we think of as high need, but to match the caregiver and the kinds of services that are necessary. Someone made reference to the fact that our regulatory system can sometimes impede the matching of appropriate care with a given individual. There needs to be flexibility in our ability to engage those issues as well. On the notions of the lessons learned, we're just obviously beginning to scratch the surface on that count, but again, from my perspective, there were a number of lessons learned from the past experiences that were shared today that are important to bear in mind, and they repeat some of the themes already mentioned. The importance fundamentally of tailoring our interventions to accommodate that variation that is inevitably going to occur with every individual. Secondly, and relatedly, the importance of the transitions. Now, we shouldn't even have to use the word transitions, actually, because we should be dealing with an individual and their problem in a holistic fashion. But the way our system is set up, in its segmented, siloed fashion, everything is a transition. And so it's vitally important that we do everything we can, to use David's word, to reintegrate the system for these patients who are of such high need. And it is unquestionably counter to our subspecialized orientation. So there's going to be a substantial change that's needed. It's important to bear in mind as well that with respect to this population, there's another paradigm shift that's, I think, relevant that I heard. And in fact, I heard Peter make reference to it just a minute or so ago in some ways. And that is, we've learned a lot in the continuous improvement process in recent years about the importance of standard work. Standard work is important. And Jeremy confirmed that in some circumstances. It is a fundamental notion in our move toward efficiency. But it's important also that standard work in these cases need to be focused not around the condition, but around the person. We need to understand better how groups of people vary in their level of function, in their level of needs, that may be related to, but not entirely driven by, what we call their condition. So the standard work that we need to start thinking of and designing with patients with multiple and complex interacting conditions is really around how they cluster in groups by function. So this is, I've just been tremendously excited and informed by today's discussion. I'm very much looking forward to the afternoon and the notion of drilling down in the following session and then moving to a set of policy solutions that can help us to advance our progress is, again, very exciting for me. So are we going to move to lunch? Well, let me then, as we move to lunch, which is the box lunches outside, I'd like to suggest that we again offer a note of thanks for all of our presenters and to all of you who commented.